So thank you for the kind introduction and for the invitation here. So damage control hemostasis. So that's quite of an extensive topic to discuss in 15 minutes. So I will do a broad overview of the damage control hemostasis. I have no conflicts of interest doing so. So trauma and mortality. So this figure shows the severely injured patients from the Royal London Hospital in 2009 and 2015. And although we are doing quite a lot better, there's still a staggering mortality of around 50% in these patients. And many of those patients actually present with a condition called trauma-induced coagulopathy. So trauma-induced coagulopathy, here defined as an INR of greater than 1.2, is actually associated with a doubling in mortality, and it is independent of your injury severity score. So to understand trauma-induced coagulopathy a little bit better, here's a quick overview of the coagulation process. So you have your vascular breach and your collagen becomes exposed. The first reaction there is to vasoconstrict your microcirculation. It happens through the use of endothelin. And then first the platelets become activated and adhere to that exposed collagen. Those platelets then release their granules to promote other platelets to actually aggregate, and then you have your first platelet clot. This is a very loose clot and can be easily broken down. Therefore, simultaneously, the coagulation cascade, as all of you know, is actually taking place, and this process is taking place on the surface of those activated cells. So on the activated endothelial cells and activated platelets. And of course, in normal physiology, you cannot have excessive coagulation without there be a negative feedback loop. So you have your anticoagulant processes, such as with antithrombin, tissue factor pathway inhibitor, and activated protein C. But also, that is to limit the amount of thrombin that has been formed, but also you have your fibrinolytic system, which actually becomes activated to tissue plasminogen activator with the production of plasmin, and it breaks down the insoluble fibrin that is formed in the circulation. So you have sort of a balance. To simplify trauma-induced coagulopathy for you, I've created this figure, and actually it tells you that you have your acute traumatic coagulopathy, which is an endogenous response to injury and shock. And later on, when we try to resuscitate those patients, this acute traumatic coagulopathy actually transitions into a more iatrogenic or resuscitation coagulopathy. Some papers do report of a hypercoagulable state in those patients. However, those patients are most likely not actively bleeding, because if you have an actively bleeding patient, it's quite unlogical to think that these patients present with a procoagulant or prothrombotic state. So to go back to the acute traumatic coagulopathy, so you have your traumatic injuries, your hypoxia, your cell death, that actually damages most of those cells, such as your endothelial cells and your platelets. And you have your bleeding, which initiated shock, and then further worsens your acute traumatic coagulopathy. So this is sort of a vicious cycle. And we know from literature that there are several abnormalities within acute traumatic coagulopathy, which is composed of endothelial damage, platelet dysfunction, fibrinogen depletion, and you have your coagulation system that is highly activated. And on the other end, you have a large production of tissue plasminogen activator initiating hyperfibrinolysis. So to recap those few slides, so TIC is a life-threatening condition. TIC shifts over time from an endogenous to a resuscitation to an ICU phase. And TIC is composed of multiple cells that become dysfunction. So to diagnose tics, we have a few things in our toolbox. We have the conventional coagulation assays, like INR, fibrinogen levels, and platelets. Although those measures tell us something about the quantity and not specifically about function, we also have viscoelastic hemostatic assays, such as your TAC and your ROTEM. And can I ask who is using TAC or ROTEM to guide their transfusion strategy? Raise up hands. So that's quite a low number. I will go to the data of those VHA-guided transfusion strategies a little bit later. So the key principles of damage control hemostasis is actually to stop the bleeding. That's the most important message I can bring to you today, because we know that if you don't stop that bleeding, that vicious cycle will continue to go on. I will tell you something about permissive hypotension, early support of coagulation, and the antifibrinolytic therapy, and I will go through the major trials. I will not go into the early use of plasma and platelets. That's for another lecture. So permissive hypotension is actually the use of or the minimized use of crystalloids. And here you have a fairly old trial they randomized in a single center in the US, penetrating trauma patients, either to the abdomen or to the chest, and randomized them to immediate resuscitation with crystalloids in the pre-hospital phase versus a delayed resuscitation in the OR. And actually what they found was that there was an improved survival in the delayed resuscitation with crystalloids. And also in secondary analysis, they evaluated prothrombin time, and actually your prothrombin time was better when you delayed your resuscitation. Of course, we are now not using crystalloids in the resuscitation of those trauma patients anymore. We are using more and more transfusion products. And the main evidence there is actually the PROPER trial, and everyone is referring to the PROPER trial as being a positive study. However, they randomized in 12 US level 1 trauma centers they randomized 680 patients and randomized them to a balanced transfusion strategy where they administer one platelet, one plasma product, and one red cells to a 1-to-1-to-2 strategy. And their primary outcome was a composite of 24-hour and 28-day mortality, and they did not find any statistical difference. There was a difference, although they were largely underpowered to detect that difference. Although they found that more patients in the balanced transfusion strategy actually achieved hemostasis, which was a secondary outcome of their study. So there are some observational trials. This is, again, data from the Royal London in 2014 in trauma surgery. And they evaluated patients, so 102 patients who received 4 units of red cells or more, and they evaluated that balanced transfusion strategy and what it actually does on your trauma-induced coagulopathy. So here you see a measure of a clotting amplitude at 5 minutes, and actually what you see is that during that resuscitation you keep that tic at bay, but you are not curing tic. So perhaps we have to do something more, like a more goal-directed therapy of your coagulation system. And Gonzalez in the US actually randomized patients to receive resuscitation using conventional coagulation assays versus a tech-guided transfusion strategy. They randomized 111 patients. They were severely in shock with a base excess of -11. And they showed that actually the tech-guided transfusion strategy had a significant improvement in 28-day mortality. However, in Europe, we performed a similar trial. Actually, here we did a more of an augmented resuscitation strategy. So we gave those bleeding trauma patients a 1-to-1-to-1 transfusion strategy, and then evaluated the coagulation every four red blood cell transfusions, and then altered those coagulation strategies based on either CCA or ROTEM or TAC. And here we did not find any significant difference in the primary outcome, which was 24 hours alive and free of massive transfusion. However, if you look at the pre-planned analysis in patients who were coagulopathic, so with a PTR, so an INR of 1.2 or higher, you see some trend towards VHA being better in 28-day mortality. And also in the group of severe TBI patients, VHA-guided transfusion strategy seems better than the conventional assays, although those numbers are quite small. For the antifibrinolytic therapy, we have actually some great evidence from the CRASH trials. And I urge you to use tranexamic acid in those bleeding patients. And it's actually based on this pragmatic study. So this is the CRASH 2. They randomized 20,000 patients to TXA or placebo. And they evaluated all-cause mortality within 4 weeks of admittance. And they showed a decrease in all-cause mortality for the TXA arm. So recently, or actually a couple of years ago already, they evaluated the use of early plasma transfusion in trauma patients. And there were 2 trials. The PAMPER trial, who evaluated plasma versus standard care, and the COMBAT trial evaluated pre-hospital plasma versus crystalloids. And they had quite contrasting results. So the PAMPER trial did show a 10% absolute mortality reduction for the plasma group, and the COMBAT trial did not show any difference. But later they tried to combine those data, and they showed that when the transfer time actually exceeded 20 minutes, your plasma transfusion was actually better in terms of mortality. So to recap, in damage control hemostasis, you have to limit the amount of crystalloids you're giving. We are giving a balanced transfusion strategy. However, we are not really sure if this is the most optimal strategy for your trauma-induced coagulopathy. There is some evidence on the use of viscoelastic testing. However, maybe not to augment your strategy, but purely to focus your strategy on. You should use tranexamic acid in those severely injured bleeding trauma patients, and maybe there's room for early plasma transfusion. So to conclude, trauma-induced coagulopathy is very complex, and I've only scratched the surface here. It shifts over time, and that's why it's so difficult to make a clear definition of what trauma-induced coagulopathy actually is. The damage control hemostasis key principles revolves around the prevention and the cure of TIC. And perhaps our current treatments are keeping TIC at bay, but we are not actually curing it. So the future might look something like this. We resuscitate our patient, and then using different modalities of your coagulation assays, to actually evaluate for that specific patient what he or she needs, and then effectuate those strategies in the patient. It could be using AI or machine learning, but we are far from this because we are not fully comprehending the complexity of TIC. Thank you.
Thank you. Thank you. Thank you. I like very much your talk because you presented a difficult subject with simplicity, and this, I mean, is something that I like it very much. Any questions from the audience?
Hi, Lori Shutter from Pittsburgh. You mentioned early use of TXA, and I would not raise any concerns with that in trauma patients. But when you looked at the specific patients in that study that had severe traumatic brain injury, GCS 8 or less, the outcomes were actually worse if you gave tranexamic TXA. It worked okay in mild and moderates and may have helped, but it did not help the severe TBI patients.
Yeah, so you're referring to the CRASH 3 trial.
Yes.
So you could argue that if you have severe isolated traumatic brain injury, that you don't have to use TXA. But if you're actually bleeding out and have severe traumatic brain injury next to that, then I would suggest to give TXA based on the CRASH 2 trial results.
Yeah. I think you just have to be careful and not apply it across the board and realize that in severe TBI there are some risks that may not be discussed as much as they need to be. Okay.
Sure.
Any other question? Okay.
Thank you very much. I have a question. If we have a patient with like subdural hematoma in the emergency department, and the doctors are deciding that they're bringing him to operating room very fast, and they don't have basically any time to wait. And I'm also thinking about damage-induced coagulopathy. Do I need to wait for the lab tests if I don't have them, or if I suspect that there is coagulopathy? Do I give him like a blood products and try to help him in this way?
So I would suggest to start your resuscitation right away. If you have your blood products, then start. However, evaluate your coagulation during that process. So if you move quickly to the OR, then you get your results a little bit later, and you can adapt to that specific coagulopathy.
Any other question? If not, I would like to leave the message, stop the bleeding, right? Yeah. And thank you very much.